coders, welcome to Visu Online. Today we are going to discuss about cerebral infarction and cerebral hemorrhage. Okay, here we go with inpatient coding training, CVA, ICD-10-CM, PCS documentation tips. Okay, first one, what is CVA? Cerebrovascular accident, which is due to acute interruption of cerebral blood flow causing neurological deficit. Okay, cerebral infarction, it is an ischemic stroke. Either it is thrombotic or embolic. Okay, so what is cerebral hemorrhage? Cerebral hemorrhage, bleeding into brain tissue or spaces. Here cerebral hemorrhage, we have one traumatic hemorrhage and non-traumatic hemorrhage. Okay, so the thing is CVA, cerebral infarction, the coding part we go with the I63 series. Okay, traumatic hemorrhage, here we go with S06 series. Okay, non-traumatic I60, I62. So next, what are the specificities in stroke and types? Okay, specificity in a stroke, we have ischemic versus hemorrhagic, capture artery and site, laterality, acuity, thrombosis or embolism. Documentation type is hemorrhagic conversion if present. Okay, so let's discuss about how to code cerebral infarction and cerebral hemorrhage. Okay, so here when the fusion is documented, if there is any acute cerebral infarction, okay, we have to code I63.9 unspecified. Okay, if there are any specific, I told you, right, there is any embolic or thrombotic or stenosis. Okay, so I'll show you one thing. So here the chart is patient is admit with any headache or any visual deficities and aphasia. Okay, these kind of symptom patient is admitted, and they found in discharge summary clearly patient is stated that the all headache which is due to cerebral infarction. See here, this is I63.9 will be a unspecified code. Okay, so when we are leading, okay, if you are in your chart, if there is specificity, okay, now we are going with CVA. Okay, CVA, we have options like, see here, newborn, traumatic, aborted, chronic, corona radiata, due to. If you go with the due to, we have options like embolism, occlusion, thrombosis. Okay, right, here separate option is embolic, next is hemorrhagic, intraoperative, lacunar, non-traumatic, old, post-procedural, thrombotic, other and unspecified. Okay, see patient, clearly patient is documented like CVA, which is due to embolism, occlusion or thrombosis. Okay, now we go with sixth option. See, I'll go with embolism. Okay, so if you click that embolism, it will ask different arteries. Okay, in your chart, patient clearly documented in this summary, either any radiology report like CT, MRI. So if there is no documentation in physician report, okay, so clearly there is occlusion and embolism or stenosis. Okay, but physician report, they in H&P note, consultation note, in progress notes, it didn't mention. So that time we have to go. We need to check radiology reports like CT, brain, MRI. Okay, in that if clearly they mention, okay, if it is cerebral artery, if it is carotid artery, if it is anterior cerebral artery, if it is middle cerebral artery, if it is posterior cerebral artery. Okay, if the physician clearly mention like posterior cerebral artery. Okay, so you have to check the laterality most, because when you are doing any CVA chart, we have to check lateralities, because if you are not coding lateralities as per the client, definitely you'll get the escalation. Okay, when you are doing any chart, definitely we have to check in a CVA charts whether specificity CVA is embolic or stenosis or thrombotic. Okay, after that we have to check specific artery, either posterior cerebral artery, okay, carotid artery, intracranial artery, we have to check. Okay, once you check the once you click the artery, okay, then we go the right. Okay, you have to check whether it is right or left or bilateral or unspecified. Okay, now I'll go with the right. Okay, so when you are doing any CVA chart particularly, we have to code all the symptoms, because as per the client's instruction, as per the coding guidelines. Okay, we have to, because there is no specific any exclude 1, exclude 2 note, it is not effective for this CVA accounts. Okay, so in patient just check whether patient is documented aphasia, apraxia, ataxia, okay, any cognitive deficit, whatever, any dysphasia, okay, if there is any aphasia, okay, if I'm click aphasia, okay, that's enough, whatever, See, and one more thing, I told you, right? See, when you are doing any CVA accounts, you have to check NIHSS score. NIHSS, which means National Institute of Health Stoke Scale score. Okay. See, whenever if a CVA chart, you have to check must and should there is radiology report or any nursing reports or ED report. Most of the time, patient clearly documented in ED report whether score will be 0 or 1 or 2 or 3. Okay. So I'm giving NHS score 1, okay, or 2 something. Okay, if you click continue, so see here lot of options will be there. If there is no particular see, and another point also we have to discuss. See, if there is any administration for TPA, okay, see, do not wish, okay, see, it will ask, okay, if there is any Visu report, computer tomography, okay, contact CT software, okay, NI administration thrombolytic is there or not agency. I told you, right, about TPA. See, we have to check. See, here we have lot of options. Okay, based on that patient documentation we need to give. Okay, if there is any endarterectomy, thromboembolectomy, if the patient is given, okay, we have to go with the PCS codes also. Particularly in my chart there is no PCS code. Okay, so I have given this. So I'm going to delete unspecified code. So I'm going to give I6341 as a PDX. Okay, see, look at here. So if there is no any particular MCC, so the DRG will be 065. Okay, so some criteria. So when you're checking the chart, CVA chart, there is a most important thing is midline shift. Okay, midline shift and cerebral edema. If the patient is given midline shift as per the CT report and MRI report, we need to raise query. Unless until without provider documentation, we should not give midline shift, because midline shift it is also called as brain compression. Okay, brain compression. So that time, so when you're seeing in your documentation midline shift, fusion is not particularly given in progression notes or discharge summary. So then we need to raise query as per the CT MRI report. Even if it is given vasogenic edema or cerebral edema without provided diagnosis, we need to raise query, because it will change the DRG. So how it will change, I will show. So before that, I'll tell you what is cerebral midline shift. Okay, so I'll show you what is midline shift. Look at here. Midline shift is the measurable physical displacement of the brain internal structure across its central axis, whereas the brain compression is a resulting clinical condition where that shifting tissue is squeezed against the rigid skull or other brain compartment. Okay, so if the fusion is given midline shift as per the radiology report, so we need to query for the fusion whether midline shift will be confirmed or not based on the fusion documentation. Okay, see here. So if you go with the compression, okay, second option. So there is option is brain, okay, which is due to there is no specific. You see, look at here. If you are giving midline shift, so brain compression, it will change the DRG. Look at here, 064. Okay, so if there is no MCC, if there is no CC, see, look at here, the DRG will be 065. Okay, as I told you, right? So another code also we gave. See, Z9282 status post administration TPA in different facilities within the last 24 hours prior to admission to current facility. Even Z9282 also, it will change the DRG. Look at here. 066. Okay, we have to check prevail. See, if the patient is admit coming from the another facility to current facility. Okay, in previous facility they have given TPA, thrombolytic agent. Okay, whether I'll tell you. Okay, what are the thrombolytic agents we need to check. Okay, see, see, there is no CC, there is no MCC. Okay, so when you are giving compression 2, 3, 5. See, look at here, G93.5. G93.5 will be brain compression, as I told you, right? So if you go with cerebral edema, G93.6. Okay, edema 1, 8, 3. See, it will also change the DRG. See, look at here, 064. So that's the reason we need to check carefully in CVA charts. First, CVA type, whether infraction unspecified or due to embolic or thrombotic or stenotic. Okay, just check whether it is right posterior artery, middle cerebral artery. Just check whether the intracranial artery or carotid artery. Okay, so after that you need to check whether patient having there is any hemiparesis. Okay, so it will change the DRG, because if you delete this MCC, see, look at here, 066 without MCC and CC. Okay, if you are adding any hemiparesis, look at here, see, D, second left side dominant. See, look at here, it acts as a CC. Okay, so we need to check carefully if there is any particular CC or not. Okay, after that we need to check in CVA mainly NIHSS score. Next, we should go and check the radiology report and 3M nursing report or any progress reports or consultation reports carefully. If there is any documentation of midline shift or vasogenic edema. If it is vasogenic edema, if it is vasogenic edema or cerebral edema documented in patient report, we can quote directly without raising query. But these midline shift and cerebral edema documented in CT reports or brain report, we need to raise query. Okay, as I told you, right? See, look at here. Do not quote imaging findings alone unless provider clinically validates. The query when CT MRI reports midline shifts or vasogenic edema, cerebral edema without provider diagnosis. Got my point? Okay. Then next, we need to check the types. So, okay, I told you, right? There is two types of CVA. One is see, look at here, specificity of ischemic or hemorrhagic. Okay, now so here next point also, when to quote sequelae. Sequelae, which means residual deficits after acute phase. If a patient are having, as I told you, right, so past 3 to 4 months he has CVA. Okay, now he coming with residual effect of deficits after acute phase. Okay, patient having any residual effects like any aphasia or any dysphasia and any hemiplegia, his current reason for admission will be same, so which is due to sequela. Okay, now that time we need to go with the I69 series. Okay, if there is no residual deficits, we need to quote history code for Z8673. Okay, do not assign sequela unless provider links condition. If there is no linkage, if there is only a history of CVA is there. Okay, and separately they mention like there is aphasia and hemiplegia. Without provider linking term, we should not take directly residual deficit after acute phase of I69 series. Okay, got my point? Then next, hemorrhagic conversion. When we need to call hemorrhagic conversion. Okay, if the patient clearly documented like ischemic stroke with hemorrhage conversion, capture the both condition as per the provider documentation. If there is no any clear evidence, okay, that time query if unclear whether the bleed represent expected evolution of versus separate diagnosis. Okay, when to quote that? So I'll tell you. CVA. Okay, CVA unspecified 1. So we have to click hemorrhagic. Then see, I told you that there is a hemorrhagic conversion. So if you click hemorrhagic conversion, it will ask whether which is due to TPA or other unspecified. If you go with due to TPA, it will ask whether aneurysm, ruptured, embolism or hemorrhage. We'll go with hemorrhage. It will ask intracranial hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, extradural hemorrhage, epidural hemorrhage. Okay, now so intracranial, intracerebral hemorrhage. So it will ask again more specific, like whether it is brainstem, cerebellum, cortical, deep, hemisphere, intraventricular, lobe, multiple, localized, subcortical, superficial, other or unspecified. So I'll go with the cortical. Okay. 1. See, look at here. If you go with due to TPA, it will show we'll get the codes like non-traumatic intracerebral hemorrhage in hemisphere, cortical, adverse effect of thrombolytical drugs. Okay, we have to code both codes. CVA code, then next this one code. Okay. If it is this might be my only chance to leave. Let's not miss this opportunity. If it is other or unspecified, okay? Same, it will ask unspecified 1. See, look at here. See, if it is unspecified, we will get the 2 codes. I told you, right? If there is specific, I told you, right, there is different codes. So now it should show non-traumatic intracerebral hemorrhage unspecified and then cerebral infarction unspecified. When there is documentation of this one, hemorrhagic conversion. Okay. Next, traumatic versus non-traumatic hemorrhages. Okay. Traumatic versus non-traumatic hemorrhages. If it is non-traumatic intracranial hemorrhage, see, we need to check if there is injury code with LOC. LOC means loss of consciousness. Okay. See, when you are doing any traumatic hemorrhage chart, we need to check if there is any cerebral edema is documented or cerebral edema or vasogenic edema. Then next is with LOC or without LOC, and LOC duration must be provided as per the provided documentation. Okay, if it is non-traumatic hemorrhage, we need to use I60 to I62 only. But in traumatic, we have to go with H06. Okay, H06, which means that is traumatic. Okay, traumatic injury. If the patient is documented, we need to check these most important like LOC, and LOC duration must be provided documentation. Okay, next. In non-traumatic cerebral hemorrhage is bleeding within the brain tissue or surrounding spaces that happens spontaneously rather than from an external head injury. So, okay, non-traumatic cerebral hemorrhage, which is due to mostly chronic hypertension, cerebral amyloid angiopathy, vascular malformation, and blood disorders medications. Okay, how it will be? See, if the patient have high blood pressure, faces constant physical stress and small deep arteries in the brain which cause them burst over time. Okay, maybe because of chronic hypertension also patients may chance to non-traumatic cerebral hemorrhage. And there is cerebral amyloid angiopathy. Okay, a condition common in elderly patients where the abnormal proteins build up in the walls of the brain arteries, making them fragile and prone to leaking. Okay, so this one also we have another code for the non-traumatic. Okay, another reason for it. Okay, next one is vascular malformation. The structural defects present from the birth, such as abnormal tangles of vessels that can unexpectedly rupture. Okay, based on the vascular malformations also it leads to non-traumatic. Okay, blood disorders and medications, as I told you, right, there is condition like leukemia, hemophilia, or the therapeutic use of blood thinners or like anticoagulants. Okay, maybe the blood disease which is caused, no, it leads to non-traumatic cerebral hemorrhage. The traumatic cerebral hemorrhage, which is due to any severe accident, severe injury. Okay, we already discussed about the midline shift and cerebral edema. Then next, okay, Viz AI reports. When there is a CVA documentation, we are doing any CVA account. Okay, as I told you, right? CVA accounts, we need to check the laterality, we need to check the specificities, we need to check the NIHSS score, we need to check midline shift and cerebral edema documentation for the racing query or for the impact, DRG impact. Then next one is Viz AI PCS codes. Okay, code only documented perform procedures. Do not code Viz AI after notification alone. Okay, capture the thrombectomy or angiography pieces when procedure is performed. So what is Viz AI? Viz AI is an advanced artificial intelligence platform widely used in modern stroke care to assist medical terms and managing protects patients with suspected cerebrovascular accident or strokes. Okay, because the time is brain during a stroke, Viz AI is designed to compress the time between a patient arriving at the hospital and receiving a small life-saving treatment. Got it, guys? So whenever if there is Viz AI report in a CV accounts, we need to code. If it is alone, we should not take. Okay, these are any Viz AI report. So we need to code this one. Okay, measurement of arterial flow, intracranial external approach. It won't affect the DRG, but we have to code in CVA accounts. Okay, so whenever if a physician documentation, like as I told you, like whatever hemiplegia, non-traumatic cerebral hemorrhage and some traumatic cerebral. See, next one is traumatic cerebral hemorrhage. Second option. Traumatic cerebellar or intracranial, whatever. See, we have options like with the loss of consciousness, without loss of consciousness. Okay, see, most of the times physician they documented traumatic brain injury and traumatic cerebral hemorrhage. Okay, if physician is irrespectively, if the patient clearly documentation there is without loss of consciousness, that time only we need to take this option, without loss of consciousness. Otherwise we have to go with loss of consciousness, status unknown, without knowing the duration of time. Okay, if irrespectively, if there is no documentation of, as I told you, there is traumatic SDH, subdural hemorrhage with loss of consciousness. Okay, if there is no specific duration, we need to code. See this code: contusion and laceration of hemorrhage of cerebellum with loss of consciousness, status unknown, as per the coding guideline or as per the coding clinic. Okay, if there is specific time duration of LOC, that time we need to code hemorrhage. Second, a brain, one traumatic, 7 subdural. Okay, with loss of consciousness, there is 30 minutes of C. So it will ask there is any brain compression, coma score, mild neurocognitive disorders, open wound head and skull fracture. Okay, as of now I didn't give anything. Okay, so whenever if you are giving any S series and injury codes, we need to check whether there is external cause code. Okay, we need to check external cause codes. Okay, otherwise we go with this one. Other specified activity, place of occurrence, whether it is residence or road, whatever, house. See, I'm giving house. Okay, in house of place of occurrence, we didn't get anything. We'll go with the other specified. Bathroom or ad. So work status, whatever we have to give in as per the patient documentation. See, look at here, we need to code these many codes. Okay, these many codes. Y series we need to code activity, other place of occurrence. Okay, when there is any documentation of A series, see, look at here, the DRG goes to 82. Okay, so if with loss of consciousness, if you are giving with loss of consciousness, it will go to 85. Got my pen? So that is the reason. If there is any documentation of traumatic subdural hemorrhage, we need to check LOC, the time duration, because with the LOC it will goes to 0.85. If it is without MCC, 0.86. Okay, so okay, got my point. So if there is any documentation of traumatic subdural hemorrhage with loss of consciousness without loss of consciousness, okay, suppose if physician doesn't mention any loss of consciousness, okay, that time we need to raise query whether the traumatic brain injury there is with loss of consciousness or without loss of consciousness. We need to raise query for that also. Suppose if there is any duration of time, okay, you need to know the duration of time. Okay, if you're confusing about the documentation, definitely you need to raise the um, duration of time also. We need to raise physician query. Okay, that time you'll get the idea, because it will change the DRG. Okay, if you are giving without loss of consciousness, you will go to 83, 82. If it is without loss of consciousness, with loss of consciousness with duration time, it goes to 0.85 to 86. Okay, based on the CCC and MCC. If you are adding, now we are, what is CVA? See, look at here. To the damaged blood vessel, the platelets undergo the transformation. Activated platelets sprout tiny tentacles and the damaged area. These tentacles that start to wave and mesh-like structures that traps blood cells and they eventually form of a clot to stop the bleeding. Okay, because of these reason, patient is getting a cerebral infarction. Okay, so lack of oxygenated doesn't supply, which is due to ischemic stroke, the clot of blood. Okay, so here see, next embolic strokes. See, look at here, embolic stroke. Embolic strokes that occur when the blood clots and blood streams eventually becoming larger than one of the smaller blood vessels from your brain. Okay, see, look at here. This is embolic stroke. As I told you, right, there is ischemic stroke. We have two types, embolic, three types: embolic, thrombotic, stenotic. See, this is next one is thrombotic. Look at here, the form of plaque. Because of plaque also, see, look at here, what is happening. Okay, look at here, rupture of artery, hemorrhagic stroke. Look at here. Okay, so whenever if you are coding CVA charts or hemorrhagic charts, see, there is a difference between CVA, whether it is ischemic or in ischemic, embolic or thrombotic or stenotic. Check these specificities. Okay, then next type of artery, whether intracranial artery, subdural hemorrhagic artery. See, subdural artery, in carotid artery, we need to check the arteries first. Okay, once we need to check the arteries, there is a separate arteries also, like in the there is posterior cerebral artery, okay, anterior cerebral artery, carotid arteries. Okay, we have a particular specific artery also. After you're selecting the specific artery, you need to check the late also, whether it is bilateral or left or right or. Okay, next NIHSS score we need to check. Next one is this AA report and this one code. And next is whether the patient having hemiplegia, paraplegia, whatever. Okay, either it is right side, either it is left side. Okay, then next we have to code as symptoms as well along with the CVA codes. Okay, CVA charts. Okay, next if there is any hemorrhagic conversion, we need to code both the codes. Okay, we need to check if there is any TPA. Okay, see, DRG I639. Sorry. CVA unspecified 1 1 1. See, if we are coding any administration thrombolytic agent, okay, peripheral vein, okay, 2 1. See, look at here, what is the DRG? 061. Okay, if there is any documentation of TPA, so most of the times TPA they clearly mention in DD reports itself. Okay, so the name what are the names is, okay, so altiplase, reticlase, tenactiplase. Okay, these three drugs, these are the drugs which is used in thrombolytic like CVA patients. Okay, altiplase, look at here, recombinant tissue type plasminogen activator or TPA, a potent thrombolytic medication which is used in pulmonary embolism or any unblocked central venous catheters. Like, see, look at here, which is used for, see, look at here, it is primarily used to treat acute ischemic strokes and heart attacks, massive pulmonary embolisms. Okay, got my point? And that's it, guys. So most of the times we need to check in CVA reports, as I told you, right? First we need to check CVA, what is CVA, okay, whether it is ischemic or hemorrhagic. Next one is you need to know the definitions first, what is CVA, what is cerebral hemorrhage. Okay, then next types and specificities, then next codes. Okay, what are the codes? It will come under acute cerebral infarction, non-traumatic hemorrhage, sequel of cerebrovascular disease, and history of codes. Okay, then next when to code hemiplegia. Okay, I explained, right? Then next when to code hemorrhagic conversion. Okay, then if the patient is documented there is cerebral hemorrhage, check there is traumatic or non-traumatic. Okay, if it is traumatic we need to check LOC. Okay, duration also. Okay, if it is non-traumatic the code will be I62, I62. Okay, then next midline shift or cerebral hemorrhage. If it is documented in radiology report we need to raise query. Okay, if the patient is clearly documented, if there is any brain compression or cerebral hemorrhage we have to put directly, it will change the DRG. And BGI report for PCS, definitely. If it is alone, the documentation we no need to put, but do not capture for this code. If they clearly mention that if there is any capture of thrombectomy and angiography for the PCS, we need to code. Thanks for watching. For more updates, please do like, share and subscribe. Thank you all.